The following podcast is part of a certified educational activity titled Elevating Care in Resectable Stage 1 to 3 Non-Small Cell Lung Cancer, Targeted Therapy and Immunotherapy at the Forefront of Multimodal Treatment Strategies. Access the entire activity and complete the post-test at peerview.com/CGJ860. Downloadable slides and practice aids are also available.
Welcome. Thank you for spending your lunch hour with us for our program Evaluating Care in Resectable Stage 1 to 3 Non-Small Cell Lung Cancer, Targeted Therapy and Immunotherapy at the Forefront of Multimodal Treatment Strategies. It's really an honor to be your chair today with this wonderful panel. We also have a large number of people online as well. The faculty, I'm Roy Herbst from Yale Cancer Center, and I'm really honored to be joined by two colleagues. I think you can go to many programs today to hear about this, but we have, I think, a great faculty, one of the best. We have Dr. Tetsuo Mitsudomi, who's the president at the Izumi City General Hospital, distinguished invited research professor, Osaka, Japan. Thank you, Tetsuo, for being here. And then we have, fresh from the presidential symposium yesterday, and actually Dr. Mitsudomi is the immediate past president of the IASLC. We have Dr. Tina Casconi, associate professor, actually now I believe professor, Department of Thoracic Head and Neck Medical Oncology, director of translational research at the University of Texas MD Anderson. So thank you both for being with us today. Our goals for today, and I'm actually really excited because I've been at the meeting the full time, and there have been a lot of amazing presentations, but the important thing is synthesis. How are we going to take this back to our hospitals, our tumor boards, our companies, our labs, wherever we work? We want to augment your knowledge of the latest evidence on targeted therapy and immunotherapy in resectable non-small cell lung cancer. We want to equip you with strategies for identifying patients with resectable non-small cell lung cancer who are candidates for targeted therapy or immunotherapy approaches. And we want to improve multidisciplinary strategies for integration of targeted therapy and immunotherapy into multimodal treatment plans for patients with resectable non-small cell lung cancer. And you've got two medical oncologists, you've got a surgeon here. I see a number of radiation oncologists in the office, in the audience. So we're going to start, and we're going to start with Dr. Mitsudomi, and he's going to talk to us about gaps and opportunities for improvement in multidisciplinary patient evaluation and treatment planning in stage 1 to 3 disease. And we'll have some time after his talk for some questions. Tetsuo.
Thank you, Dr. Herbst. Good afternoon, everyone. So I'm going to talk about the patient evaluation for the resectable stage 1 to 3 non-small cell lung cancers. So this is the data from Japan. So this is the 5-year disease-free survival and overall survival in the patient resected in 2010. And as you see, even for the stage 2 patients, disease-free survival at 5 years is like less than 50%. So even though the stage 2 disease, lung cancer is already a systemic disease. As you see that recurrence pattern, if you divide into local or distant, the distant metastasis is becoming more common as the stage increases. So we have to control the micrometastatic disease, which is not detected at the time of operation. So that's why the platinum doublet chemotherapy, adjuvant chemotherapy, has been the standard of care for the resected non-small cell lung cancer, but the increment of the survival is only 5.4% at 5 or 6 years. So this is clearly satisfactory. So after the introduction of the targeted therapy and immunotherapy in the stage 4 disease, then it came to ARIA disease. And if the driver gene is negative, then we have the post-operative immunotherapy. And if the driver gene is positive, for the EGFR, we have the osimertinib post-operative therapy. For the ALK fusion, we have the alectinib. And also we have the neoadjuvant strategy for the driver gene negative. And also recent trials also show the very nice results, so-called sun-weight strategy, which is neoadjuvant followed by surgery and post-operative adjuvant immunotherapy. So now we have a lot of the options. So how can we select the best strategy for your patient? So I think that there are 3 points you have to think about. One is anatomic extent of the disease, so which is staging, and also histology of biomarkers, then the patient condition. But this is so complicated process, we need to have the discussion in a multidisciplinary team, which I think is most important thing. And I'd like to go into detail for these 3 points later. And actually, these 2 papers show that if the patient was discussed in the MDT, has a better survival compared to the patients who are not discussed in the MDT. So these are 2 separate papers, but those 2 papers show clearly that patient discussed by MDT has better prognosis. Then I go to the biomarker history first. So as you know, the driver gene mutation, if I think that Dr. Herbst will discuss this in detail later. But DORA or ARENA shows a very nice disease-free survival. And in the case of the DORA, OS is also prolonged. And for the PD-L1 expression is very important determinant of the efficacy of the perioperative treatment. For the IMPOA-010 adjuvant treatment, if the PD-L1 is more than 50%, the hazard ratio is best. And also the meta-analysis of the neoadjuvant perioperative IO trials, even though the PD-L1 negative is still survival advantage is present, but if the PD-L1 is more than 50%, the best outcome could be obtained. And then we have to think about whether we should give if the driver gene is negative, we should give the adjuvant treatment or neoadjuvant or perioperative therapy. So there are many choices. And this is a comparison of the neoadjuvant perioperative approach versus adjuvant approach. And there are many pros and cons, but I like to highlight those several things. So most things for the immunotherapy is neoadjuvant approach is high efficacy due to the presence of the tumor antigens and intact lymph nodes, which is important for the priming of the immune cells. However, the main concern of the neoadjuvant perioperative approach is 15 to 20% of the surgery is cancer because of the progressive disease or adverse events or other reasons. In contrast, in adjuvant, there's no delay in surgery. Also, you can analyze the big resected specimen for biomarkers or histologic typing. However, even in adjuvant, in the case of the IMPOA-010 trial, only 70% of the patients after surgery reach the adjuvant therapy, and the compliance of the 1 year atezolizumab is not so high. And you may be aware of the recent publication of the ISLC consensus recommendation. So I'd like to quote the statement from this recommendation consensus paper. So the immunotherapy is not recommended for the patient with EGFR ALK mutations. And neoadjuvant chemo IO is preferred to upfront surgery, which is adjuvant approach for patients with non-small cell lung cancer. For the stage 3A/B disease, the agreement is very high, 94%, but stage 2, there is some controversy, about 65% agreement. And for the adjuvant approach, the indication may be dependent on the PD-L1 expression. If the PD-L1 is negative, it's discouraged. Consider when the PD-L1 is 1 to 49, and if the more than 50%, it is recommended. And then I move to the patient evaluation of the patient condition. The PS, age, organ reserve is important, but for lung resection, the most important thing is the cardiopulmonary function. And there's an established algorithm for the evaluation of the cardiopulmonary function. So I'm not going into detail, but essentially if you screen the cardiac function first, then go to the spirogram. If the spirogram is not so good, you may put the patients on the exercise test. So this is a widely accepted algorithm for determining the patient operability. And then we have to think about the staging or lymph node status. For that purpose, we need to have the contrast-enhanced CT, PET, invasive mediastinal staging, including EBUS and brain MRI. And on the right, you see this is I like to say the N2 disease is so heterogeneous. So the single station, small discrete nodes to the multiple invasive coalescent lymph node. And there are two things of the operability. One is technically resectable or not. If the lymph node is invasive to the surrounding structures such as superior vena cava or trachea, the surgery may be very difficult. And, but even with a very big bulky lymph nodes, the resection is possible. But the question is whether it is oncologically meaningful to remove such big nodes. So there's different opinions, of course. And this is a paper taken from the paper that compared the 10 international guidelines. And they show what the guideline says for the different N2 status. For example, potential resectable N2 disease if the single station non-bulky to multi-zone bulky nodes. And you can see that there's a lot of the heterogeneity, even in the guidelines says there's no good agreement. And this is data I borrowed from Dr. Harinouchi from the National Cancer Center in Tokyo. And he performed the questionnaire survey, which treatment do you select for these different stage situation. I mean, I'm sorry, this is too small to read, but the yellow dots indicates N1 disease, orange N2, and red is N3. And this orange indicates adjuvant approach, adjuvant IO approach, and this is neoadjuvant IO surgery approach, and this is CRT, so Pacific regimen. And this survey was done in 2022, so there's no option for the sandwich strategy. But anyway, you can see the lot of the heterogeneity, because this is a JCOG, Japan Clinical Oncology Group Institute, so those are all lung cancer experts, but the opinion about the selection of the treatment differs so significantly. So I'd like to show that several cases. This is a big tumor with N2 disease, but single N2. And this one is also single N2, but it's like 3 centimeters of bulky lymph nodes N2 disease. And third one is a multiple bulky invasive N2. And this is a coalescent invasive and multiple N2. So it is not very difficult to say uniformly which treatment is the best. So that's why the MDT discussion is very important. But for these cases, we did give the checkmate 816 regimen, and this patient is alive with the evidence of disease after 6 years. And this why also checkmate X16, and 6 years after the surgery, still patients no evidence of disease. And this patient was a relatively old cases I borrowed from Dr. Yoshino from Chiba University. And he treated him with chemoradiation followed by surgery, but this patient is still good after the 8 years. And the last case I borrowed from the CHEST guidelines, so I don't know how the patients are treated, but probably this is, you agree this is inoperable cases. And you also have to think about the difficulty of the surgery after the neoadjuvant treatment. And on the left, I showed you hilar fibrosis comparing the neoadjuvant ICI with neoadjuvant chemotherapy. There appears no big difference, but this paper says that fibrosis is dependent on the presence of the N disease, especially higher metastasis. If the clinical N plus disease, 59% they found higher, moderate to major higher fibrosis. On the right, you see the data from the NeoSTAR trial, which is a comparison of the neoadjuvant nivolumab with neoadjuvant nivolumab ipilimumab, Dr. Cascon's study. But this is the surgical outcome, and they classify the surgical difficulty using this 4 scale. So one is easier from the normal lobectomy, 2 is similarly, same difficulty, 3 is a little bit difficult, 4 is very difficult. And you see that about 40% of the cases, you will find that surgery is more difficult. So the surgical difficulty varies, but sometimes it's very difficult. So you have to prepare that. And sometimes the bronchoplasty or angioplasty may be required. However, in the trial basis, this is checkmate 16 comparing the control arm, neoadjuvant chemoimmunotherapy with the neoadjuvant chemotherapy. But for most of the parameters, the neoadjuvant immunochemotherapy has favorable features. So as a statistics, you don't have to be so worried much about the difficulty of the surgery, but sometimes it could be very difficult. And this is the recent case that I brought from the Dr. Stani of Nakina University. This patient, 70-year-old T3N2M0 disease, and this patient received a neoadjuvant immunochemotherapy, but it didn't work very well. But they went to the surgery, but at the end, right, apparovectomy, the coronary resection was required. Operation time was 11 hours. Blood was 1.5 liters, so this was very, very difficult surgery. But anyway, the patient went well after the surgery, so that was good. So this is my take-home message. So patient with resectable non-small cell lung cancer should undergo a multifaceted evaluation that considers biomarkers, TNM status, proposed surgical procedures, and technical requirements, patient physical function, the patient preference. And this should be discussed in the MDT. And finally, last message is surgery after neoadjuvant immunotherapy could be difficult. So surgeons skilled in advanced surgical procedures should operate, and this statement is also included in the ISS consensus paper. And thank you very much for your kind attention.
We have time for a couple of questions. But Tetsuya, I'll ask you the first question. So in Japan, I can tell you what happens in the US, is there a uniform agreement what is surgically resectable and what isn't? So when you're sitting at tumor board, how much do you argue, this tumor might just be a little too large? Do you try to make unresectable tumors resectable with the immunotherapy? How much of that variability goes on?
So the technical point, the resectability border is relatively clear, but if that resection is oncologically meaningful or not is different from the people to people sometimes.
Right. Tina, what happens at MD Anderson? I used to be there for a while.
Yeah, no, that's probably one of the hottest topic, right, tumor board. And I think we've definitely evolved and grown as a multidisciplinary team based on the nuances and the wealth of data that we have at this moment in time from the neoadjuvant, the adjuvant, and the perioperative approaches. I have to say, as you know, Roy, I think that we are very much of a neoadjuvant multi-D, neoadjuvant institution. So we're fortunate to have the surgeons on board to really attempt, even when there is a borderline, right, resectability, the chemo IO, right, for the non-drivers, and then reevaluate with rescans and reconvening in tumor board. So I want to emphasize that the second step in those situations when there is a borderline resectability is critical. And that's very helpful because the patient is part of that journey in which we are involved too. So the patient understands that we're attempting an approach as an extrapolation from the standard of care, and then there will be a rediscussion. So So that's a very important point as well, as we think about patient wishes and what's the best service, right, that we can provide to the patient in
Right,
this
it needs to
setting.
be some sort of shared decision making.
Absolutely.
But that actually sets up the question that I'm going to ask you, Tetsuya, that came from, I'll just give first names, Richard. If a patient has surgery and doesn't have neoadjuvant therapy and you find they have N1, N2 disease, which will happen, what do you then? Do you do adjuvant chemotherapy? Do you do adjuvant immunotherapy?
So I think depending on the PD-L1 status, if the PD-L1 is more than 50%, I surely give the adjuvant immunotherapy. But it's negative, then I do not.
Yeah, I would agree with that. And again, a live question. Don't forget to go online so you can get your credit. Go ahead.
The question is like the last patient you showed. He had 11 hours of operation and he had 1.5 liters loss. And when I looked at the scan, it looked like an invasive lymph node. Perhaps I'm wrong. But I just wonder, these patients are not clearly resectable, they're borderline resectable, and we're all excited about the data. But perhaps in some patients, we may be making them a disservice. They get chemo IO, we think they're going to be downstage, they're not, and then we are sort of ending up with chemo radiation. We don't know that much about this toxicity. Pacific 2, I think, is a negative trial, correct? And in a way, if you've given IO with the chemo IO, that's in your system for another two months. Essentially, you're giving chemo, IO, and radiotherapy. So the question really is, should we be more purist and not do the borderline patients? And I've got another small question. Do you think this is the reason why all the neoadjuvant studies before we give chemo, 95%, and the Village Spanish study, 95% got surgery. When you do chemo IO, it's about 15% of patients are not getting it. So we are losing patients. Now, I think it's an extra 10% that perhaps were not resectable to start with.
Okay, take that first, Dr. Mitsudomi.
Yeah, it's a very difficult question. So I think that the last case I showed you was very controversial cases. So this patient did not respond to immunochemotherapy, almost not at all. So, but the Dr. Stanley's group was so aggressive to go to the surgery, but we don't know whether that strategy was correct. This is a relatively recent patient. We don't know the long-term results. So. But I cannot answer the question. It's very difficult.
No, I think, Tina?
No, I think the point is well taken, and for sure there is a small fraction of patients in this, 17 to 22% who drop out, right, in the perioperative window, who perhaps was not resectable, from the beginning. However, I want to be provocative and mention that we will have trials that will attempt to address that question, right? The conversion of a borderline resectable of an unresectable in the non-N3 setting. I want to emphasize many times when there is this comment, there is, the surgical community is preoccupied with now having an N3 disease getting into the resectable setting. We're talking about still at a stage 2, 3B, T3, T4, N2, that could potentially be converted from a non-resectable or borderline resectable, and that's the MDT bridge. But there will be, I think you're absolutely right. I think we need real-world data to really tell us what's happening in that 20% who is really non-resectable. You're absolutely right. From what we have right now, we don't have that data. And as investigators, we're all asking the sponsors, the companies, and the current practices to really come together to understand what happens there.
I love the interaction. We're going to take 2 more questions, then we have 2 more presentations, but please go ahead. This is great.
And I'm Dr. Lin from Taiwan. I have 2 questions. And because according to the consensus, they only check the EGFR driver mutation. From your experience, you have your patient, and how many of your patients will receive the NGS study and prior neoadjuvant and chemo IO?
Great question.
And if the German patient just like MET or HER2, you still prescribe neoadjuvant IO for this patient?
This is perfect for Tetsuya. When he was president of the ISLAC, they set up all of this. He talked about it yesterday. What do you think?
Yeah, for the NHS, right?
Yeah, NGS. Yeah.
Yeah, so we don't do the NHS. So in Japan, it is not reimbursed to perform the NHS before the surgery. So, I mean, very small panel. But so your question, if we found another driver's mutation like HER2, right? Yeah, but theoretically, HER2 adjuvant therapy, HER2 targeted therapy, if it's available, then we like to, I mean, the trial, if you test HER2 inhibitors after the surgery, that could be positive, but we don't have the evidence right now. So I think as of now, we should treat them as a wild-type patient, right?
So I'll tackle both parts of the question very quickly. So for the first portion, NGS, I can tell you personally in my practice, there is no patient who undergoes neoadjuvant treatment without a molecular profiling. To me, that's paramount because you can really provide a disservice to the patient. And if I have to really start treatment while I'm waiting for the results, I usually send both the liquid and the tissue. If I don't have the tissue and this is a never smoker, I rebiopsy, reprofile, making sure that the team knows I'm rebiopsying not for diagnostic purposes, but for core biopsy for appropriate tissue profiling. And in that window, I will just proceed with one cycle of chemotherapy without the immunotherapy as I'm waiting for the completion of the workup if I have to treat. As far as the what do we do, very excellent question for the non-classical, right, EGFR ALK alterations that we're used to see excluded from these trials. Unfortunately, the answer is that we don't know because we haven't really looked at these populations across all the trials. We don't have the data. The data is there, but it's not been really collected and presented. So I would discuss the patient in tumor board always with my medical oncologist colleagues, and it really depends on the tumor burden and so forth. I feel that there is an IPDL1. I think that perhaps in those situations I tend to do immunotherapy.
Okay, we probably have time for one quick question, and then we'll move on to the next.
I'm Corina van Es from the Netherlands. I'm a radiation oncologist. And what I see is that a lot of people are not operated at all after the stage 2 grade of the chemo-immuno, and they are virtuous because it's not a good operation, it's irradical, or they can't be operated at all. And these patients are treated less good than in the past. So keep in mind that we have a lot of research done on board, also for the radiotherapy, unforeseen M2, and it doesn't work with patients with lung cancer. So what we are trying to do on the other side, we want to treat best, and I think you should, but on the other hand, don't do any cowboy because we treat these patients not on the right way. That's what I'm saying, want to say.
Okay, I'll answer that one. Well said. And the Pacific trial, in my opinion, is probably one of the most historic trials ever done with durvalumab in the adjuvant setting after chemoradiation. We now have the LAURA trial. So yeah, these decisions are tough. As I think we've ascertained, they're not exact decisions. They're decisions that require shared decision making, and they can vary from Houston to Japan to New Haven to Boston to San Diego. So I'd love to keep talking, but I have 2 more presentations, so I'm going to talk now. And I'm going to talk about integrating targeted therapies in resectable stage 1 to 3 disease. So I'm just going to remind that in resected disease, the ADORA trial, now actually it's about 4 years since we first presented the data, took patients with EGFR mutated lung cancer. The question is, if you have EGFR mutated lung cancer, why not treat it in the early stages, or why wait till the late stage when it's widely metastatic and almost impossible to cure, and treat it early? And this trial was a multinational trial, worldwide, 1/3, 2/3 in Asia, 1/3 in the rest of the world, stage, stratified by stage, EGFR mutation type and race. These are all patients with R0 resections, randomized to osimertinib 80 milligrams or placebo. I think many of you know these data. They were presented early, a few years earlier than we expected because it was planned for a hazard ratio of 0.7, a 30% improvement, and this is the data that we got. So here you can see the hazard ratio is 0.23. These are the updated data from early last year, but you can see a 77% improvement, though the top black curve being those patients who got osimertinib, daily for 3 years. It was a 3-year treatment, somewhat empirical, I'll get to that, or the placebo control on the bottom in the orange. And you can see the differences at 24 months, 36 months, at 48 months, 70% versus 29% progressing. And here you can see when you add stage 1 patients in, this was a secondary endpoint. Many of those stage 1 patients are cured to begin with. You can see the hazard ratio 0.7 or a 73% improvement. So this established targeted adjuvant therapy could be used, and it's the standard of care in most of the world with osimertinib. Of course, the drug has great brain penetration, and I'll show you that now. And then looking at a forest plot, this is just an excerpt from the forest plot that's in that first paper from 4 years ago in the New England Journal of Medicine. You can see that the benefits seen across all stages and with or without adjuvant chemotherapy. Adjuvant chemotherapy was a choice in this trial. So we can ask if you can get rid of the adjuvant chemotherapy because it wasn't done in a randomized way. Physician and patient discussed should they get adjuvant therapy. Most of the stage 2 and 3s did. Most of the stage 1s did not. About 60% of patients overall got adjuvant therapy. And here you can see updated DFS across subgroups in the overall population, and you can see both mutation types benefit, whether or not patients got adjuvant chemotherapy, and all the other prognostic factors. Now here you can see the updated DFS by stage for the ADAURA, and for people who like to look at curves and not hazard ratios, you can see stage 1B up top, stage 2 on the lower left, stage 3 on the lower right. In all cases, hazard ratios quite compelling. Of course, the more benefit in the more advanced disease, 0.22 for stage 3A, 0.33 hazard for stage 2, and 0.44 for stage 1B. Patterns of recurrence. So this is why you use a systemic therapy and EGFR therapy, because these patients will recur. The metastases to the lung, the brain, the bone, the liver, and you can see that the placebo group in the orange and the osimertinib in the blue, you can see that in those patients who got the placebo versus the osimertinib, there's more recurrence in the lung, the brain, the CNS, the bone, the liver. And here you can see, I think this is very compelling data. This is showing that the first site of recurrence being the brain. And remember, osimertinib is a 3rd generation EGFR TKI, mutation specific, so it has fewer side effects of rash, diarrhea, and so forth, and brain penetrant TKI, small molecule oral drug. And you can see that the blue curve on the top are patients who got the osimertinib, the orange is the control, placebo, and you can see at 2 years, 97% disease-free in the brain versus only 77%. And then at 48 months, 90% disease-free in the brain versus only 75%. Now, these were the data that we had prior to ASCO 2023, and many still said, where's the survival? But I would say preventing metastases in the brain. We did a session here on EGFR in the same room yesterday, and our patient advocate told us that brain metastases is a very big concern for many patients, obviously. So survival, and here's the survival, and the survival in the ADAURA trial at the 20% maturity, which was the preset endpoint, with a hazard ratio of 0.49. So again, the upper curve, the osimertinib, the bottom curve, the placebo control, and you can see that it's a 51% improvement in survival over the course of the curves at 60 months or 5 years, 85% surviving versus 73%. And these are a lot of patients. If you look worldwide, EGFR mutations being about 10-15% in the US, 20 to 40% more in Japan, China, and elsewhere. And if we find these mutations and we know them beforehand, this is a paradigm that should be used. And here, when you add the stage 1 patients in, you get the same 0.49. The survival with or without adjuvant chemotherapy, the benefits seen in both. Keep in mind, these are slightly different populations. Those who get adjuvant chemotherapy or not, that's why the control arms look a little different. And then you always have to ask, what is the cost? Of course, there's a cost when you give a drug versus a placebo. But the good news is most of this is low grade. The grade 3 and 4 it's almost all low grade diarrhea, paronychia, dry skin, and you can see close to the bar in the middle, only 3% severe diarrhea, but there is some. and I'm sure many of you have treated patients, as have I and my colleagues on the podium here. You have to dose reduce, you have to nurse patients through, you have to teach them how to deal with side effects. Because again, the control is nothing, you're done. But with a 51% improvement in survival, I encourage my patients to use this. And I just want to end with a story. Josh Fidler, my mentor, one of my mentors at MD Anderson, who described the metastases cascade. He used to talk about a decathlon. A tumor had to, the Olympics were just a month ago. The tumor has to go through 10 different steps, break out of the microenvironment, get into the blood, survive in the blood, nest in a distant site, matrix metalloproteinase, angiogenesis. The idea now that we have surgery and we have adjuvant therapy, and to my colleague in the audience, radiation too, there was no radiation allowed in the ADAURA trial because we were worried, but I think it will be added in the future. And then you can see you add the targeted therapy in, and that basically improves outcome because you prevent metastases to the brain, the liver, and the bone. Just a couple of things going on with my colleagues, Dr. Yilong Wu and Matsura Suboi and Tom John and others. It's wonderful when you work on international trials, you make friends and colleagues and you work worldwide. This is a worldwide effort where now we've analyzed the blood samples for minimal residual disease, and cutting to a chase, and I don't know how well you can see this, but on the left we have those patients with osimertinib, and the right those with placebo. And if you can see it, you can see basically that in the osimertinib arm, the red are those patients who have detectable disease. We only detected disease in about 12, 13 patients post, we had about 200 patients for whom we had samples, and we only detected disease in 12. Well, that's pretty good, or it means that the tests are not sensitive enough. It's probably both. But interestingly, in those who had the osimertinib, the minimal residual disease went away on the osimertinib, but sadly, in most of them, it came back after the 3 years of treatment. If you look at the placebo group, see all that red there? Those are patients, they're getting a placebo, so they recurred, and you could detect the minimal residual disease. Why is this important? That's the next step here. More precision medicine, where we're going to be measuring in the blood and treating some patients longer, some patients less, based on what we find. And this is just showing the same thing. Those are those 13 patients on the right, and you can see with MRD at baseline, and you can see that in most cases it went away, but in more than almost all, it came back after we stopped the drug. So we have a number of other studies ongoing now. There's ADAURA 2. I get called all the time. People here probably wondered, what about stage 1A? It wasn't in the protocol. There was a benefit even in the stage 1 patients, but those were 1B. And then, of course, the ISLAC keeps changing the staging on us, so that even those of us who have been doing this for 30 years need to use the cards. But in any event, there is an ADAURA 2 now going on with even the earliest stage 1A tumors. This trial is accruing very rapidly, and those data should be presented soon. Then there's this trial called Target, which, of course, for us in the US, we think of the store down the street. But Target is basically a 5-year trial now, so treating for 5 years. And this is important because why was 3 years chosen? 3 years was chosen in the ADAURA trial because 1 year hadn't worked with erlotinib, and we felt 4 or 5 years was probably too long in the initial trial. We knew we could give more osimertinib than the other first and second generation EGFR inhibitors because they were somewhat more toxic. But now Target's going to have a 5-year treatment, and this is ongoing. So it's a platform trial. The other thing about this is there's much more meticulous attention to collecting the blood samples, so the MRD will have it not only on 200 out of 800, but hopefully on more, 80% or more of the population. And then there's NeoADAURA, we all love neoadjuvant trials. We just start talking about that, make tumors smaller. The other nice thing about them from a scientific standpoint is you get the full sample out, you can do sequencing, single cell sequencing, which cell populations are alive, which cells are dead. But this trial is ongoing in the neoadjuvant setting for EGFR mutant disease, placebo plus chemotherapy, osimertinib plus chemotherapy, or osimertinib alone. This trial is mostly being done in Asia, because you can imagine finding these patients is hard, but it's much easier in Japan and China than in New York. And then this is a slide that Tina gave me to include, but I love it because it's showing that why stop at EGFR? And this is an umbrella trial, a beautiful umbrella, which basically allows, it's through the Lung Cancer Mutation Consortium, something that Bruce Johnson, Paul Bunn, Mark Chris and others set up years ago with the first discovery of the mutations in the US, which allows us to, you find a patient that has a mutation and you can do a neoadjuvant therapy. I actually just recently treated someone with ALK in this way. And then there's the LAURA trial. These are patients who don't get surgery, chemoradiation. We know that on the Pacific trial, while there was some evidence of benefit for EGFR mutant patients, it was not great. So now these patients can get osimertinib. In this trial, they were treated till progression, and this was the curve that Dr. Ramalingam showed at ASCO with a hazard ratio of 0.16. So, really an amazing result. And here the EGFR inhibitor osimertinib was used until progression, and this early survival curve shows a hint of benefit, but it's still early as well. And then Alina, again, this is the paradigm now for all the targeted agents. Are we going to be able to do a randomized trial for each of them? Probably not. There was one done for alectinib. This is interesting because rather than giving a choice of chemotherapy like we did in ADAURA, they designed it platinum-based chemotherapy versus alectinib. So it's a little bit of a different bird, but this trial was done in the adjuvant setting, and this trial was positive. You can see for stage 2 and 3A disease on the left, or for stage 1B to 3A disease on the right. Again, two different groups adding in the ones on the right. You can see the hazard ratios in 0.24 on the left and 0.24 on the right, so 76%. So it's a paradigm. You have a target, you give the drug, you prevent recurrence. Even if it doesn't ultimately affect survival, in my opinion, you're preventing morbidity, brain metastases, and other disease. So with that as background, you guys ready for a case? Okay, we got a 67-year-old woman, a never smoker, presents with a persistent cough. Chest CT shows a 3.4 centimeter left upper lobe mass. PET scan demonstrates a 3 times 2.6 centimeter solid appearing left upper lobe mass with an SUV of 5.3. Pleura is normal, and there's one hilar lymph node, so no distant disease. EBUS confirmed the hilar nodal involvement, and transbronchial biopsy showed invasive lung adenocarcinoma. So Dr. Mitsudomi, Center for Biomarker Testing, what do you think? You agree?
Yes, of course.
Okay. Tina?
Absolutely. This is a never smoker with a potentially resectable tumor, most likely very resectable. It's paramount to understand what should we do next based on profiling. Okay,
I agree. I think it's still not done as much as it could be. What percentage of patients in Japan are you're probably pretty good in Japan.
Yeah, 40. Adenocarcinoma, like 40, 50%, right?
Only 50%?
Yeah, adenocarcinoma, right.
Okay. Do you ever see patients that haven't been profiled, like where the physician hasn't profiled the patient?
Yes, I think so. The penetrance of the testing is relatively high in Japan.
What about you, Tina? What do you think?
Well, we try to profile everybody. If they're not profiled coming from the outside, we make an effort to, as I said, rebiopsy in addition to the liquid biopsy, which is, done immediately as soon as they step into the door.
I think they've got to be profiled before they get to that tumor board, right?
Absolutely. And if not, as that tumor board, right, is deciding, because that notion is going to be critical for the tumor board decision.
So let's see. So she undergoes biomarker testing, and the NGS panel reveals EGFR exon 19. Good thing we profiled. LVATS upper lobectomy reveals a 3.4 centimeter invasive adenocarcinoma, moderately differentiated, multiple lymph nodes, 1 level 7, 1 11L, 2 peribronchial. So it's a stage 3A. Do we all agree with that? Yeah. Okay, we got ourselves a 3A now. Okay, so we're sitting there at the tumor board. In a stage 3, I would probably give chemotherapy. In fact, unless there was a contraindication, this patient's at very high risk of recurrence. And then the osimertinib, and as per the ADAURA trial. Radiation's an interesting one. 6 years ago, we probably would have done radiation, right?
No, I don't think so. In Japan, the post-operative radiation is not so common. Not popular.
We used to do it before the lung art trial. What do you think?
Yeah, absolutely. I think the lung art really changed, right? How we, disposition this patient in the post-operative setting. I have to say that I still tend to refer my patients to the radiation oncology in the multidisciplinary approach. And of course, if there is margins positive and so forth, that's still considered in our practice. But for the N2, that's a discussion. But in many cases, it's done or not done. It depends really from the patient factors, as you know, Tetsuya also mentioned, the same one that we use for surgical resection.
Okay, I think we're ready. They told me we're going to move on. And now I'm going to let Tina talk, because then we'll have all the data on the table. And she gave a wonderful plenary the other day. And she's going to talk to us about navigating decisions about neoadjuvant, adjuvant, or perioperative immunotherapy in resectable stage 1 to 3 non-small cell lung cancer.
Thank you very much, Roy. That was a wonderful overview. It's really tough to follow two giants, but I think this program is really set up to look at all lenses, right, of the resectable from stage 1 to stage 3. So here, really, we wanted to give you an overview of the current landscape for patients with resectable disease with non-genomic alterations or with genomic alterations that are potentially sensitive to IO. So here we're really looking at the IO-based approaches. We have a neoadjuvant approach, as you have heard so far from Dr. Mitsudomi, with the CheckMate 816, 3 cycles of neoadjuvant Nivo plus chemo. In that trial, remember, we have an AJCC 7th edition. As Dr. Herbst mentioned, things have changed and continue to evolve, in terms of staging, so keep that in mind. Also, keep in mind that for the approved regimens, we have some PD-L1 based guidelines based on jurisdiction. So based on the FDA and the EMA, the guidelines may change based on the PD-L1 positivity. And then we have 2 approved regimens for the adjuvant paradigm with surgery, so resection up front, followed by adjuvant atezolizumab for the Empower 010 in patients with PD-L1 positive, whether that's 1% or 50% based on the FDA and EMA. And then the Keynote 091 or PEARLS, where we have the pembrolizumab in the adjuvant setting following chemotherapy for all comers. And then in the perioperative setting, we have several trials. I'll just highlight the Aegean with the perioperative durvalumab added to a backbone of neoadjuvant chemotherapy, followed by adjuvant durvalumab, just approved a couple of weeks ago or so as a new standard of care. And then the Keynote 671 with the perioperative pembro paradigm approved in October last year. And then we have several trials with very impressive data that we're still waiting to see maturity or approvals. This is a table that really gives you the wealth of the patient population characteristics, as well as the primary endpoints, what has been done in terms of treatments that have been evaluated in this trial, and then, of course, the EGFR ALK status that has been excluded for most of the trial. For the Aegean, there was an initial proportion of patients that has been then removed from the modified intention to treat population. These are the responses, the PCR, pathological complete responses, and MPR across these trials. Please remember a very important point. Across trials, different pathological assessment criteria have been utilized. So you have up to 3 cycles for the CheckMate 816 with immune-related pathological criteria assessment, 24% PCR rate versus 2.2%, with a PCR defined as absence of viable tumor in both the resected primary lung cancer and the sample nodes. And then you can see in green up to 4 cycles for the perioperative regimens. And here we have for the CheckMate 77T, the immune-related pathologic assessment criteria. For others, we have the ISLC criteria for the Aegean and the Keynote 671. We do not know for other studies what the criteria used, whether they were ISLC, immune-related, and so forth. But you can see overall across the trial a range of 18 to 25% PCR and MPR that can go overall between 30% and 55-56%. A very important analysis from the Aegean trial that we've seen in the New England Journal of Medicine from Dr. Amack last year. In a nutshell, among the patients who were ctDNA positive at baseline, so cycle 1, day 1, all patients that had a PCR after the neoadjuvant component or the neoadjuvant phase of the treatment, and more than 90% of those who had an MPR had ctDNA clearance at the first day of cycle 4, as you can see from the graphs. And you also can see that patients without a ctDNA clearance were unlikely to achieve a PCR, and patients who achieved ctDNA clearance in the durva arm versus the placebo arm were more likely to have a PCR with a positive predictive value of 50% versus 14%. So here you can see the survival outcomes, the EFS and the DFS, of course, different endpoints based on the trial, whether we're looking at the adjuvant, the neoadjuvant, or the perioperative paradigm. We try to give you here really the most updated data as maturity, right, continues to evolve. So you can see from the Empower 010 for the population of patients with stage 2, 3A disease, PD-L1 positive, an hazard ratio of 0.7. You can see the median survival rates in orange and gray. You can see for the keynote overall similar results. You can see from the neoadjuvant for the Checkmate 816, just recently presented at ASCO, the 4-year survival updates. So we have an hazard ratio of 0.66 for EFS. Again, overall survival trending in a positive direction, favoring the chemo-nivo neoadjuvant, but not yet hitting statistical significance. And then you can see on the farther right the perioperative paradigms with the Aegean, the NeoTorch, the Keynote 671, and the 77T, all published trials, and that's why particularly selected for these slides. You can see here between 2-year and 4-year, very encouraging hazard ratio from 0.4 to 0.68. And then here you have the OS, as I was mentioning, for the Empower 010. We have seen with at least 5-year follow-up. So I want to mention this is the longest follow-up for a cancer immunotherapy trial in resectable non-small cell lung cancer at 0.77 across the 2 stages with PD-L1 positive disease, that is trending in favor of adjuvant atezo. And then you can see again the neoadjuvant 0.71 with the Checkmate 816 favoring the chemo-nivo, and then the perioperative, the Keynote 671 4-year updates with an hazard ratio of 0.72. You will see today in the perioperative strategy 2 session updates from the Aegean trial with a presentation from Dr. Hemak, so stay tuned. We had some information from the abstract, but I think it's going to be very important to see that presentation, to see how the data continues to evolve in the durvalumab perioperative trial. You have seen yesterday this data presented in the plenary session, the NeoCOAST-2 trial, which was really very innovative and such a pleasure to be part of in terms of designing, participating, driving with intellectual contribution, and really with an incredible team effort. The incorporation of science, of emerging science, into a backbone of standard of care. And so you can see here, this is really a global multi-arm platform studies where we can keep adding arms as new science emerges. So here specifically, we enrolled patients with resectable stage 2A, 3B non-small cell lung cancer with an EGFR ALK type resectable disease into 4 arms. That tested in a perioperative fashion a backbone of chemotherapy plus novel agents followed by surgery and continuation of novel agents in the adjuvant setting. So specifically, the primary endpoint of the NeoTorch-2 was the PCR, where the PCR, the safety and tolerability, and the key secondary endpoints, MPR rate, EFS, and feasibility of surgery. I want to point out that this trial was not really designed to make direct statistical comparisons across the arms. You, in fact, can see that there are descriptive statistics because really the primary intent was to look for preliminary efficacy signals by calculating the PCR rates that could guide us into more analysis that could lead to further exploration of promising agents into larger potential phase 3 setting. I want to mention that specifically for the presentation yesterday, we presented the preliminary efficacy and safety data from arms 1, 2, and 4. I think there has been a lot of interest and questions on why arm 3 wasn't presented, simply because that is still ongoing. So we haven't completed the analysis of different doses tested into that arm 3, but I will reassure you that the data will be presented as soon as mature at upcoming meetings. So as far as arms 1 and 2, those were consisted of neoadjuvant durvalumab plus platinum doublet chemotherapy with the addition of either oleclumab, which is a monoclonal antibody targeting CD73, or monalizumab, which targets NKG2A. Why those two agents? Because Dr. Herbs has done incredible groundwork in the unresectable setting with the COAST trial, where these agents have really shown promising activity, and because in the NeoCOAST trial that we reported last year, just one cycle of these agents in a chemosparing fashion led to numerically higher MPR rates as compared to durvalumab alone. And then the arm 4, for the first time in the neoadjuvant and perioperative type of paradigm, we tested neoadjuvant Dato-DXd, a TROP2-directed antibody drug conjugate, plus durvalumab and single-agent platinum chemo, followed by surgery and adjuvant durvalumab. And so you can see here the major results in terms of activity. In the modified intention to treat population, a PCR was seen in 20%, 26.7%, and 34.1% of patients in arms 1, 2, and 4, respectively. And the MPR rates were 45%, 53.3%, and 65.9% in arms 1, 2, and 4, respectively. So definitely numerically a promising greater activity of these novel treatment combinations as compared to our historical control and benchmarks, with the highest really rates in the Dato-DXd arm with an ADC. If we look at the stratification by a baseline PD-L1 TPS, you can see that higher PCR rates were seen in patients with a PD-L1 TPS greater than or equal to 1% as compared to those with a TPS less than 1%. And you can also see that when we look at PD-L1 subgroups, definitely there were higher PCR rates with increasing PD-L1 cutoff across the 3 arms. I would encourage you to really use caution when you look at this data and interpreting this data. The numbers, the denominators are overall small, but definitely an encouraging signal with a higher PD-L1 expression. And specifically, you can see that perhaps the differences between the subgroups are even more notable in arms 2 and arms 4. I want to mention, although not here, that the safety profiling of all the 3 arms was absolutely manageable, specifically for the Dato-DXd arm, which was really a novel a regimen brought into the perioperative setting. We really saw only grade 3 and higher treatment-related adverse events occurring in 18.5% of patients in the neoadjuvant phase, and only 7.5% of patients discontinued treatment due to adverse events. And this is actually very encouraging if we look at the historical benchmarks, and specifically in this setting if we look at the Aegean. So in conclusion, as I mentioned, in the perioperative non-small cell lung cancer setting, these novel treatment combinations had promising efficacy, numerically higher PCR and or MPR rates, with overall a manageable safety profiling comparable to currently approved regimens in terms of surgical rates as well, with the higher rates in the Dato-DXd arm. So we hope to really bring what we learned from the NeoCOAST-2 in the larger testing, in the larger phase setting, and I'm sure that translational analysis will help us a lot in what to do next. I want to also quickly mention an important analysis that I believe has triggered a lot of interest yesterday in the presidential, and also I understand online and on social media. This was an analysis that has been requested for a very long time, and that many investigators have attempted to do from in an exploratory fashion from Kaplan-Meier curves out there online from the different studies. So the CheckMate 816 and the CheckMate 77T are the really 2 trials that perhaps can help us to understand in an exploratory fashion what's the contribution, right, of phase, and what should we do for these patients, whether continuing therapy or not. So a very complex analysis. Again, extremely fortunate to be part of a big team with statisticians, medical oncologists, so an incredible group of people to really understand how to really trying to compare in a fair manner these very different different population, different heterogeneous cohorts. So you will see different type of propension scores applied really to adjust for clinical pathological characteristics. But you can see here in a nutshell that landmark EFS, so EFS landmarked at time of surgery, so from definitive surgery, led to favoring the perioperative approach as compared to the neoadjuvant nivo-chemo approach with a hazard ratio of 0.61. Please take this data with all the variables and caveats of two different populations, and also by subgroups. PCR, you can see that there is a PCR, non-PCR, so by PCR status, you can see that there is really a benefit favoring perhaps the perioperative versus the neoadjuvant nivo plus chemo, regardless of the pathological response, with an hazard ratio of 0.56 for the PCR, 0.65 for the non-PCR, and very surprisingly by PD-L1 status, or perhaps not surprisingly, because we had seen trends favoring the perioperative approach in the PD-L1 negative disease, but really not much difference in the PD-L1 positive disease. Same thing for the stage 1B and 2 versus stage 3, as a ratio of 0.53 and 0.63, potentially favoring the perioperative approach versus the neoadjuvant. In terms of safety summary, really no major differences, no new safety signals across the two paradigms. So with this, let's just jump into a clinical scenario, patient case. We have a 57-year-old male, a former smoker, a 50-pack year history, really asymptomatic, found to have a 6-centimeter suprahilar mass. These are the pulmonary function tests with an FEV1 of 58%, the LCO 90%, with overall very reasonable ECOG performance status of 1. These are the images from the PET scan, so you can see the suprahilar mass with the FDG positivity. And workup is done with an MRI of the brain negative. Otherwise, outside of the chest, no other disease. Invasive mediastinal staging tells us that this is a T3N1 disease with a hilar involvement. And biomarker testing tells us that there are no actionable aberrations in the context of standard of care PD-L1 negative disease. So what do you do with these patients? It's interesting to think that for these patients, the surgery followed by adjuvant chemotherapy and ICI could have been an approach, but I think we're all really inclined toward a neoadjuvant therapy with larger stages of the disease. And then, based on these presentations I just shared with you today, really, what do you do next in the perioperative setting? Following surgery, for which patients would you consider an adjuvant immunotherapy?
Do you think it matters that, oftentimes in the US, many of the people that operate in the community are not boarded thoracic surgeons, they're more cardiac surgeons, and I wonder if that makes a difference in our country.
I think it does a lot, and I think Dr. Mitsudomi mentioned, right, our JCO consensus paper where we really were vocal, right, regarding the importance of expertise in thoracic maneuvers, right, specifically for these patients.
And to be comfortable with that, as he showed that you can do it.
So I want to mention for the patients with residual viable tumor that yesterday I had the honor to discuss very important abstracts, including the Keynote 671 pathological analysis of a residual viable tumor and its association with EFS. I think it's actually an important point to think about the residual viable tumor as we think about what to do next in practice.
Great, well, thanks, Tina. Well, we're out of time because we had so much interaction and questions, but that's good. It's been a great program. Great meeting. Thank you, Tina. Thank you, Tetsuya. Thank you to PeerView. See you next time. Thanks, everyone.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/CGJ860.